and things too. So feel free to come off video. I'm gonna put it up on my screen so I can see reactions from folks if you're smiling or frowning at me at least a little bit. So I'm really excited to be here. I'm Caleb Levell, as Mary had mentioned. I'm with the American Cancer Society. And one of the reasons I'm super excited to be here is that prior to joining the American Cancer Society in 2017, I was the director of the Indiana Cancer Consortium. So I was with you all for about 6 years in Indiana and really cut my teeth in comprehensive cancer control work, and I was with the consortium for about 6 years. So it's nice to see some recognized names and faces on the call. What I'm going to be presenting today mostly is this new report that we have from the American Cancer Society, Responding to the COVID-19 Pandemic, Improving Cancer Screening Care in the U.S., talking a little bit about the process we did to put together these national recommendations. But what I think I'm also really excited to share is that there's just a lot of national momentum and national energy around cancer screening right now. And I want to make sure, you all have probably seen some of it, but make sure that we kind of look at it all holistically and then think about what some of those national recommendations are in the Indiana lens and then the Hoosier lens. So I'm really glad to have Dr. Champion and Dr. Henry on to kind of help us think about what that means for the cancer control plan in Indiana, what that means for our systems, and what that means for our state policy-wise, and et cetera. Just a lot of different places we can take this. So please do, as I'm going through, think of questions that we can handle as a panel or handle as a group here, as a collective that we have on the phone to kind of think about what next steps in Indiana could look like. So with all that said, all that introduction, I'll start hopping through the presentation here. So quickly, I'll do a little bit of orientation around cancer and the COVID-19 pandemic, what it's looked like and where we're at. We'll look at the national response. I'll talk about the American Cancer Society's Get Screened initiative, talk about what we put together as the American Cancer Society National Consortium for Cancer Screening Care, briefly review the consensus recommendations that we released. We have 9 recommendations, and then I think we'll go into the panel discussion. So this is stuff that you all have probably seen before, but as you all know, on March 13th, there was a national emergency declared due to COVID-19. March 13th, 2020, a national emergency declared due to COVID-19. CDC recommended healthcare systems prioritize urgent visits and delay elective care. The American Cancer Society and other specialty organizations advised patients to postpone elective care, which included cancer screening. And that shut down cancer screening kind of nationwide for a while. It wasn't until July 2020 that the American Cancer Society updated information on cancer.org to kind of reemphasize that cancer screening is still a priority. Today, waves of the COVID-19 pandemic still put health systems in different places of how they are being able to respond and kind of get back to screenings. Vaccinations are definitely helping with COVID, but there still are waves and there still is stresses on the healthcare system. And what this looks like for the patient is fear, stress, grief, uncertainty, difficulty navigating the pandemic, and really just kind of dramatic drops in cancer screening. What that looked like immediately after immediately in March 2020, there was a report that came out, I think around July 2020 from NCI, and what it reported was that because of the missed screenings, modeling studies show that there would be about 10,000 excess deaths between 2020 and 2030, just because of the drop in screenings that we had in those first 3 months of the COVID shutdown. Can you also see my screen okay? I think I've just lost one of my monitors. Mary, I can't see it. Can you give me a?
Yeah. Okay,
good. Sorry about that.
No problem.
And one other thing to bring up is that while screenings have kind of gotten back to some historical baselines of where we would expect screenings to be, screening disparities have increased for people with greater social or economic barriers. So really what this means is the barriers of medical mistrust, access to care, insurance status, financial security, housing, food security impact, all affect the likelihood of being screened. All those things were exacerbated during the COVID-19 pandemic. So those populations, those folks that We're already having challenges, barriers, apprehensions to get screened, procrastinating screening, probably seeing even greater impact because of the COVID-19 pandemic. So where we're at now, this report came out in January 2022 from Epic Research. So we're 2 years into the pandemic, and we still have concerns that we haven't reached historical baselines. So for breast cancer, we're about 2.7% down, colorectal cancer 3.4% down, and for cervical cancer 10% down, and screenings that we would expect historically to be seeing year-over-year comparisons. What this means is just to catch up for the missed screenings in 2020 to 2021, it's 3,800, more than 3,800 additional colorectal cancer screenings each week, and 230 additional cervical cancer screenings each week that needed to take place in 2022. So what's needed of the healthcare system is astronomical, and what we need to overcome just because of delays, disruptions, and things that happened during the past 2 years because of the pandemic. We're really going to see it's going to be tough to kind of get just make up for those missed screenings, let alone get back to baseline screening rates. What all this means, I like this little chart from the American Cancer Society or from CDC. What all this really means is that during the COVID-19 pandemic, we saw reduced access to care that leads to delayed routine screenings, which will eventually lead to later stage diagnoses. Which will have to modify treatment plans and everything else. And what we're going to expect to see in the long term is an increase in cancer mortality. So this is what we're fighting against whenever we're talking about the COVID-19's impact on cancer and cancer care. And 1 second, I'm going to try to get my next monitor on before I go on. See if that fixes it a little bit. So that's kind of a little bit of an orientation of where we're at and where we've been. And as we're going forward, on February 2nd, we had President Joe Biden and the First Lady both announced the reigniting of the National Cancer Moonshot. The goals of this kind of reigniting of this are to reduce the death rate from cancer by at least 50% over the next 25 years. It really calls on the private sector, foundations, academic institutions, healthcare providers, and all Americans to address cancer and those folks that are families and folks that are impacted by cancer. And it really calls for jumpstarting cancer screening to address those missed as a result of the pandemic and to help ensure that everyone equitably benefits from the tools that can prevent, detect, and diagnose cancer. So this was the first thing. This was February 2nd, 2022, that really kind of kicked off this these national efforts to increase screening. At the same time, the President's Cancer Panel, which is an independent board that kind of gives recommendations to the President's administration about what to do around cancer and to the different governmental agency arms that address cancer, they came out with their report, Closing Gaps in Cancer Screening, Connecting People, Community Systems to Improve Equity and Access. It had 4 major recommendations: approving and aligning cancer screening communication, facilitating equitable access to cancer screening, strengthening workforce collaborations to support cancer screening and risk assessment, and creating health information technology and promotes appropriate cancer risk assessment and screening. And I just realized I didn't put the link to this report in the slides here, so I'll drop it in the chat or share it with Mary so that you can share it afterwards. But really a great, I think, like 80-page report that has specific recommendations on what to do nationally to improve cancer screening and really focus on that through a health equity lens. So that also came out February 2nd. And then in close follow-up, the American Cancer Society National Consortium released our consensus recommendations responding to the COVID-19 pandemic, improving cancer screening care in the US. We released February 16th this report, and there was a little bit of coordination with us and the President's Cancer Panel to kind of get our reports out as kind of a 1-2 punch, as a kind of a coordinated approach from here's kind of the government kind of perspective on it, and here's kind of the private sector, the nonprofit sector's perspective on it. And our report was a consensus-built report with a lot of different organizations involved, and I'll kind of talk you through the process of what we did to get to our 9 recommendations. Before doing that, just a little bit more information on the Get Screened initiative from the American Cancer Society. So The Get Screened initiative is this enterprise-wide initiative from the American Cancer Society to really address and respond to the COVID-19 pandemic and really put a prioritization around cancer screening nationwide. We have 6 different building blocks across the enterprise on this. The National Consortium is what I'll be talking to you about today, but also just wanted to let you know we had funding and support, staff support, and different initiatives coming in around state and coalition leadership and building activities at the state level. We had a national public Get Screened public awareness campaign launch. We had a health system screening interventions. I think now we're up to over about 100 different systems that are involved in this health interventions work that are getting direct technical assistance and support from the American Cancer Society and partners to increase screening rates at their systems. Our research team really wanted to understand the impact of the COVID-19 pandemic on cancer screening and outcomes. And then there was a whole policy campaign with the ACS, with the American Cancer Society Cancer Action Network, to kind of pursue different public policy solutions, what currently was in the works, what needed to be relooked at or reassessed, other policy analysis things. So a really comprehensive look that started February 2021 or so that we really got all this kicked off. The National Consortium for Cancer Screening and Care started March 2021. And really we were putting together leading organizations and scientific advisors to identify key areas of opportunity where we as a nation can catalyze change by these 3 kind of goal statements: accelerating, strengthening, and mobilizing around sensible but bold cancer screening and care activities. So whenever we're talking about accelerating activities and accelerating different recommendations, we're really talking about accelerating those responses to longstanding and emerging barriers to cancer screening and care. Those areas that have worked for us over time, that we already have good infrastructure in place, that we already know are evidence-based, making sure that we put the appropriate funding and prioritization and kind of focus on those activities that we know work, making sure that we get those into the right places, expand those areas. And that's kind of what we tackled with our Accelerate recommendations. We also packaged up some strengthen recommendations. And on our strengthen recommendations, we were looking at those places that our healthcare system is most vulnerable. We were looking at places where maybe the COVID-19 pandemic really showcased some of those, really showed and highlighted some of those vulnerabilities that we have, where we're disconnected as a healthcare system. And we really kind of thought about where those disruptions were, how they increased inequities, and how that how we can kind of strengthen those up to better address those in the future. And then finally, this mobilized goal statement is really around, okay, so we have these recommendations, but what's next? How do we act around them? How do we get some united response going forward and actually implement around these recommendations to see some national movement? So we really brought together a diverse, multi-sectored and influential cohort of voices that were dedicated to the safe and equitable recovery of cancer screening and care. Government agencies, cancer advocacy organizations, professional societies, research institutions, our national roundtables, et cetera, survivors, like really trying to get the right voices at the table that needed to help us identify the problems and come up with the solutions that could work. So here's just a quick members list of who y'all have. I'll just leave it up there for a second for the recording, and then also you guys can have the slides and have kind of this particular list of folks. But you'll see a lot of national organizations, a lot of cancer advocacy groups, some different industry partners, and it was really a great conversation of, you know, the kind of the who's who of folks in cancer control that helped think through these things and bring opinions to the table and kind of what their priorities are, what their agendas were, and kind of a really nice compromising session to get to our national recommendations. So here are the recommendations that we put together and that we released. And again, we had those 3 goal statements: accelerate, strengthen, and mobilize. We really focused our conversations around the first two goal statements within our recommendations. So which areas can we really accelerate activity now, and which areas do we really need to strengthen? So whenever we're talking about acceleration of activities, we talked about national partnerships. We think that we come together pretty well in national partnership areas. We have national roundtables, we have state coalitions, comp cancer work like the Indiana Cancer Consortium and other comp cancer infrastructure across the nation. And we have these places that really do a good job influencing the adoption of evidence-based cancer screening interventions and policies. It's what the Indiana Cancer Control Plan is. It's what these webinars are talking about. It's all the good work that Mary and team do and the different members of the Indiana Cancer Consortium. So we need to accelerate that activity, and we need to lean into it, was the recommendation from our national consortium partners. The second area was a place that really, and this really aligned with the President's Cancer Panel. And again, purposely, we had the President's Cancer Panel as members of the National Consortium, again, because we wanted to coordinate these approaches and make sure that this seemed like, while there were differences and nuances to our recommendations, that there were alignment and that we can really act on this stuff together from all of our different perspectives. So you'll see again in coordinated messaging, accelerating a coordinated innovative campaign to promote cancer screening as a public health priority. The American Cancer Society has done this through the Get Screened campaign, but the American Cancer Society also partnered with CDC and the National Comprehensive Cancer Network to release kind of a national letter that got 76 different sign-ons from organizations to really promote, okay, we need to reprioritize cancer screening, we need to get back to screening. So there's a lot of ways that we can coordinate our messaging around cancer screening and also coordinate our messaging to the public around cancer screening. How do we make it more accessible to the public, help them understand differing screening guidelines, help them understand what the healthcare system looks like now in the time of COVID. Another recommendation that we need to accelerate was around proven programs. And this is really what you can think about is like, these are the evidence-based recommendations that we have in the community guide that we have from NCI. These are evidence-based recommendations that we have in our cancer, that we put in our cancer control plan state to state, things that we get from the CDC. And really accelerating screening efforts by supporting and expanding proven programs that effectively reach communities that are historically excluded and underserved. You'll notice throughout all these recommendations, we really try to touch on health equity. We really wanted to make sure that was a focus. And I think you see that in the President's Cancer Panel report too. And I know those are conversations that you're having within the Indiana Cancer Consortium as well. Proven programs, another kind of focus area here was navigation, community health workers and patient navigation programs. Things that really can help people not only get into screening and outreach into understanding where we need to get to screening, but the follow up to the screening, follow up to diagnostics, follow up to treatment, and follow up through their cancer care plan. Quality measures is another place where we have a measure a metric, an indicator to measure what we're doing. You'll see that people tackle those items. So there's places where there are gaps in the measurement systems where we're not measuring follow-up to colorectal cancer screening, for example, from a stool-based test. So we want to accelerate the adoption of improved quality measures, accountability measures, and institutional goal setting that prioritize equitable outcomes. And then finally, there were things that were happening during the pandemic that were responses to healthcare systems that we thought were innovations that could be accelerated to think about for cancer screening. So a lot of work, a lot of kind of mass adoption and forced adoption of telehealth programs would be an example there, or mass adoption of non-clinic based screening programs. So thinking of mailed fit programs where you're mailing out stool-based tests and collecting those back in, thinking about all the options that we have there for colorectal cancer screening, whether that's Cologuard or other stool-based tests that you can lean on and to kind of take some of that pressure off of the healthcare system. Whenever we were talking about our consensus recommendations around strengthening, these are areas where we thought there was some vulnerability in our healthcare system. So the first area that we really talked about that I think probably was exacerbated during the COVID-19 pandemic just because of miscommunication or duplicative or kind of challenged communications, kind of public trust in our healthcare systems, public trust in the medical information that we're getting, strengthening trust in public health and healthcare systems by using a forward-looking whole person approach. So not only is this recommendation looking at the medical mistrust that we might have in different communities that we're trying to approach for whatever the historical reasons may be, but also looking at addressing kind of that whole person approach from not just looking at cancer screening, but also addressing their other chronic diseases and chronic illnesses and their other social economic issues that may be preventing them from getting cancer screenings. Really taking that all into account, especially in our outreach programs that we have across the state and across the nation. Another place that we looked at is comprehensive preparedness plans. So we often see comprehensive preparedness plans for natural disasters, but a lot of times what's absent in those is how do we manage chronic disease and cancer screening or cancer care within those preparedness plans? So can we strengthen healthcare systems and community preparedness plans for health disruptions by including cancer and other chronic disease care and plans? So this is not only, in the case of a pandemic, but also thinking about natural disasters, other things that cause disruptions to healthcare, making sure that there's a plan in place across systems, across our state systems, across our healthcare systems, that we can, come back and not have to be so reactive as we were throughout the pandemic. And I think another thing here is really making sure that cancer screening, cancer screening was kind of labeled as a non-essential healthcare at the beginning of the pandemic, but really trying to go forward labeling cancer screening as essential healthcare. It is an essential service, and you can kind of see that by some of the data, some of the modeling, where we're at now with kind of missed screenings, how that's going to have repercussions in longer term down the line for this. So we also want to make sure that we're documenting and understanding cancer disparities and strengthening the recommendation is strengthening the understanding of outcomes of cancer screening care by collecting and utilizing demographic and social determinants of health data. A member of the National Consortium really put this best as we were having conversations of saying, we say we're tackling healthcare, health equity and health disparity and cancer disparities, but it's really hard to say that without having the right national data systems tracking what those disparities look like. So it's hard to really address that whenever we have gaps in the data collection systems that are in place, and we're not seeing full representation in our data system. So it really needs to be strengthened kind of nationwide. And I think there's probably some roles here for states to play too, thinking about their own cancer registry data, their own collection systems with BRFIS or other places of what this looks like, and making sure that we have the data we need to make the decisions we need to make. And then finally, transdisciplinary teamwork. So strengthening transdisciplinary teamwork in support of healthcare delivery. We talked about, and within healthcare systems, there was some really great coordination across kind of interdisciplinary care. So people helping to pick up places, finding primary care providers, taking on new roles and responsibilities, different specialty doctors taking on new roles and responsibilities, responding to the COVID-19 pandemic. But this also needs to be extended into our community outreach programs and those non-clinician and non kind of healthcare setting folks, but those community settings, those community places that we have also need to be included in kind of this teamwork approach to addressing the public health issues and the public health problems that we have. So cancer screening being one of those. So that's a lot of information that I just threw at you, and Dr. Champion and Dr. Henry, a lot of information that I just threw at you too. Hopefully it's got your wheels spinning just a little bit. I'm going to talk just for one more minute about just a few other things, and then we'll get into the panel discussion, I think. So just as we're going forward, looking at 2022, the National Consortium will continue to meet. And really what we're trying to do is make sure that people know these recommendations, do presentations like these, get folks, the smart folks in the room like Dr. Henry and Dr. Champion to think about these, what it looks like for the state, local level. We want to try to think about how states are already implementing around these and how they could implement and strengthen their implementation efforts around these activities. And then we're going to, at the national level, try to track the progress towards these recommendations going forward. So that's the difficult task that I have kind of going forward, what this looks like across the nation, evaluating all that. I have a list of different resources. You can watch some of the different public forums that we held throughout to kind of get to these recommendations. Not only did we have the 20 organizations participating, but we also had nearly 900 participants across public forums giving their own feedback, their own experiences, their own advice on what these recommendations should look like. So you can watch recordings of those. We also have the full list of resources there on the left of everything that came out whenever we released the recommendations. You can find all of that at the link at the top there, consortium.acs4ccc.org. And then the only other thing that I want to mention is I hope that you all know about our national ACS Led Round Tables. We have the National Lung Cancer Roundtable, National HPV Vaccination Roundtable, National Colorectal Cancer Roundtable, and our Navigation Roundtable. And these are places where really we're seeing the implementation of these recommendations. And I'm really excited, if you didn't hear, that we're launching 2 new national roundtables this year. The American Cancer Society is bringing together partners to help launch a breast cancer roundtable and a cervical cancer roundtable. So really excited about these initiatives. So I was previously, had privileged to be the director of the National Colorectal Cancer Roundtable. And these, you can think of these as just doing the stuff that you all do on the state level at the national level. So bringing the people to the table, having the right conversations, identifying problems, coming up with solutions, just really great and inspiring work. So I can only applaud the work that they do and applaud the work that you all do at the state level through comp cancer coalitions and everything else that really drives, I think, and catalyzes the change that we need across the state for policy, system change, et cetera. So I'll stop there and open this up to conversation, definitely.
Awesome. Thanks so much, Caleb. And I'll definitely make sure to get your slides out and all the information, as well as the recording to everyone after. Definitely a lot of great information, a lot to process. So I'll go ahead and get started and throw some questions at Dr. Henry and Dr. Champion. But if anyone that's on, you have any questions, comments, anything you want to add in the chat, please do. So our first question is, Caleb talked a lot about the COVID-19 pandemic and the impact. We know that that's compounded a lot of health inequities in cancer screening. How do you think Indiana's responding, and how do you think you've seen Indiana be affected? So I'll open that to either of you to start.
Thank you, Caleb. That was an unbelievably comprehensive summary of what ACS is doing. And I think many of the things that you mentioned are things that we can partner and help with locally in Indiana. What we're, to specifically answer your question, Mary, because I made a lot of notes and I think we need to stay focused to help answer. I think we are getting back to pre-COVID conditions in terms of the healthcare system very, very slowly. Things are still not moving the way they should. And I think that screenings are going to lag even beyond opening up the healthcare system, because our healthcare system was always challenged in terms of prevention and early screening, because so much is expected of a healthcare professional in a 10 or 15 minute time they have with patients. And so I think there are a lot of things that Indiana could do and are looking at doing. I represent the community outreach and engagement arm of the Indiana Comprehensive Cancer Center, Simon Comprehensive Cancer Center, and we are putting in plan looking at partners statewide to help mainly with a lot of these things for prevention and early detection. So in answer to your question, I think it's going to take us a little while to get back, but the things that Caleb has mentioned, primarily communication, helping removing barriers, things like that, our healthcare systems in Indiana are trying to implement.
Yeah, I would add to that. And again, thank you, Caleb, for an excellent presentation. I'm Len Henry with the American College of Surgeons Indiana chapter in the Commission on Cancer. And so one of the mechanisms that the American College has tried to impact getting back to screening is in partnership with the American Cancer Society, this Return to Screening initiative, where organizations basically could participate in a very easy trial to meet COC recommendations by setting measures and trying to spur innovation in reaching the population for screening to see if those interventions were effective in increasing screening. So we funnel that out through all the COC approved cancer programs in Indiana.
And I'll just say too, from, you know, it's been tough to track all the cancer screening data, kind of in national data sets. We still don't have all the answers yet, but kind of system by system data sets that we might have, maybe some from different health plans, or like, you know, I was able to give some research from Epic Research, who's, you know, kind of followed this. One thing that we've noticed, or I think we've noticed, and maybe it's more my own personal belief, is that those folks that we would expect to come back to screening have come back to screening. So those people that have health insurance, those people that, those folks, a lot of places, systems are seeing that kind of leveling, getting back to baseline. But what we don't have, and this kind of gets to one of our recommendations about really understanding the disparity data, not having all the best collection data, is those folks that were not in the system, or those folks that have lost health insurance, or those folks that have lost jobs, or have whatever impacts, or those folks that have, we've always struggled with getting into the healthcare system. So that is the picture that I think is still not clear from national data sets, or even maybe some local health data sets, or the data sets that you have within systems that you're working with has a better picture at that. But I think that that's somewhere that we could see a lag, and we could see an ongoing problem, kind of what Dr. Champion is talking about too, of really.
Yeah.
So Caleb, the greatest predictor of future screening is past screening. Any behavior, and you're absolutely right. So the people who were not where they should be have been marginalized by the COVID epidemic. And I think it's going to take a different type of look, and involving many people, the patients and the healthcare providers, the healthcare system, the insurers, to reach those people that have been marginalized even more. I could talk about some of the ideas we have in community outreach and engagement, but I think I'm going to let Dr. Henry say something now.
No, I was just going to comment on, yes, it appears to push people on the margins further away from screening, but it's also, I think, a supply issue from the healthcare provider's perspective. So the COVID pandemic, health screenings, it's obvious it's the right thing to do, but the fact of the matter is, for health systems, it's not a real big revenue generator except for downstream things. And so when systems are under pressure, losing a lot of money from reduced business due to COVID, all your patients in the hospital have COVID, and you're putting off elective procedures, impact on systemic therapy administrations for people with cancer, it really cuts into the revenues of health systems. So the incentive for them actually is almost away from screening because they want to devote resources to the things that really generate revenues to keep them afloat. You compound that in this past pandemic with what happened after, which is some of your healthcare staff get sick, and so you have to backfill. And then followed by the Great Resignation, where no one has enough healthcare staff at all anymore. It's not just trying to find, reach the patients out in the community, but actually getting them access with the wacky incentives that drive healthcare revenues presently in place, that actually incentivize large healthcare systems to focus on it as a priority, I think is also a barrier.
Thank you. I think you guys touched on kind of what my next question was going to be, and a lot of the pressures and the realities of what is happening within the health systems. And so I think, Dr. Henry, especially with those incentives and where the money is, because at the end of the day, bottom lines matter. So I was just going to see if there was anything else you thought besides the incentives, and again, open to everyone, about how we can help medical teams work more effectively. I think you touched on one, getting staffing in and be able to support that from a base organizational level. But do you think there's anything else that we can do to help medical teams and organizations more effectively?
So I have something there. I think we need to rely not only on our medical providers, who have so many other things to do, but on communicating to individuals in ways that they understand, that they initiate screening. I think we're going to the ability to self-screen and things like cervical cancer, HPV self-sampling, if it's ever approved by the FDA, would be, and cervical cancer screening is the one that's really down. Colorectal cancer screening, I think Dr. Henry and I talked prior to the webinar about how confusing the guidelines are, and that guidelines vary and physicians vary in their understanding of those guidelines. And in one of your presentation slides, Caleb, I think you talked about risk assessment. That's key to colorectal cancer screening. But there are other avenues that we have to depend upon other than just the healthcare system. We always have to link, but if we can get to the individuals in the community to help support what they can do to increase screening, and then tie them the key is tying them to medical care system with positive results and following up on those. So we complete the screening cycle.
Yeah, I think those are great points. I think, there were a lot of problems with screening before the pandemic. And the pandemic has made it worse for a period of time. My sense is that we're just going to have to do it differently. It's maybe a good time to talk about like the bias towards colonoscopy, which kind of persists through my peer group physicians. We just kind of grow up thinking really colonoscopy is the default screen for colorectal cancer, and it is a great screen, there's no question, but there's a portion of the population that will just simply never assent to it or submit to it. So there are the other screening tests, FIT tests, Cologuard. There's some problems with the expense of Cologuard, but FIT test is very effective, proven screening method. Just trying to get past some of the cultural barriers within the medical profession that don't want to accept anything other than a colonoscopy, and then getting these into the hands of people who will actually do it and return it, outside maybe even of the relationship of a primary physician, because I was surprised to read in the presidential report that one of the significant barriers that was not listed was having a lack of a primary care physician, because that's in the community where I work. I can tell you that a substantial portion of patients, even if they have a primary physician, are not seeing them. So there's one less voice in their ear, keeping track of them, trying to make sure they're up to date with age-appropriate screening. But innovation is good. I think innovation is going to be really important. I have to believe it's coming. Honestly, if you think about a FIT test, all there would really need to be, someone needs to invent a toilet that can combine a hemocult test with it. And then we will have solved the colorectal cancer.
Yeah, and I'll tell you where some of that the most impressive, innovative kind of stuff comes through is from community health centers, federally qualified health centers across the country. So with the National Colorectal Cancer Roundtable, we have an 80% in every community campaign trying to get people to strive for 80% screening rates. And we have a National Achievements Award program. And one of our Achievement Award winners one year kind of had a poop on demand program. So they had a whole system set up, and our people came in, they helped give them a stool-based test and kind of processed it right, got it right then and there. So, there's also mailed FIT programs that have been very successful. But these all take, to the staffing issue, they all take planning and physician champions and executive champions at the facility, administrative champions that can kind of really understand and kind of make sure that test is not only completed, that stool-based test is not only completed, but then there's the links set up to follow up on that stool-based test to get the follow-up colonoscopy. So there's a lot of other challenges that need to be kind of thought through and addressed, but the evidence that's there and the resources and the best case examples are there. We have those on the National Colorectal Cancer Roundtable website. We probably have those within Indiana-based healthcare systems and community health centers already. It's just devoting that prioritization to screening, and then to both of your points, having the right communication and getting the providers educated on current screening guidelines and everything else. Luckily, with colorectal cancer, we do have the USPSTF last year did come down to age 45, so we pretty much are at least universal on at least for average risk. And I do know the President's Cancer Panel talked about a little bit more about aligning screening guidelines. I try to avoid that with conversation with our national consortium, because I thought good luck getting the USPSTF and ACS and all the other guideline focus groups to kind of commit to aligning those. But I do think there's good communication strategies that can be done to educate providers that then kind of help them educate their patients.
So one thing I'm trying to do is get some money for an implementation study to work with the rural health clinics, whereby anyone who turned 45 and had not been previously screened for colorectal cancer would be automatically mailed a FIT kit with follow-up by some type of navigator or community health worker. That is one of the strongest evidence-based interventions to increase colorectal cancer screening there is. And countries with national health systems like Australia mail these out on a person's birthday at age 45 or 50, whatever the guidelines are. And embedding that within the healthcare system, with the patients recorded in the healthcare system, may not get those patients who have never been to healthcare system, but it will probably get all patients who've had anything to do with the healthcare system. And it's a starting place. And then they're linked automatically too with a provider. But that's something we're thinking about to increase colon cancer screening.
Thank you. I appreciate those thoughts. And I think we started to turn the conversation a little bit and really talk about the recommendations and where we are and where we aren't in Indiana. But specifically, how do you think we're aligning with these recommendations, and where are we already working and responding, whether that was efforts pre-COVID or efforts that have been started during COVID?
After your crash course of seeing the recommendations and me trying to spit out as much information as possible in 20 minutes.
You had a lot of information.
Well, I can, from a big high level view, I think the cancer control plan aligns very nicely with the vast majority of both the ACS document and the president's task force document. The main priorities, or two of the four main priorities, specifically have to do with breast cancer screening, colorectal cancer screening. So one of the things that I personally like as a mechanism a lot, in the ways that I think we can push it forward as a consortium, is through the advocacy route. There's several organizations within the state. The physicians have a group which has an effective advocacy arm. The American College of Surgeons has an effective advocacy arm, and the American Cancer Society Cancer Action Network has an effective advocacy arm. And in Indiana particularly, we have some inside advantages with some members of the legislature having medical backgrounds. So I think one thing going forward, at least, I think the consortium aligns well and has done a lot of good work towards those objectives already. But going forward, I would welcome sort of more of a unified advocacy push between the organizations for things that matter, not just with regard to health cancer screening, but with regard to other important cancer issues.
Absolutely. Vicki or Caleb, is there anything else you wanted to add to that one? Okay, yeah, I think Dr. Hunter really touched on it, talking about our cancer control plan. So within this last edition, 2-year plan, really recognizing where we were with COVID and the pandemic, and that we weren't going to make a lot of great movement, right? I think everyone on the panel today has really discussed about the focus and the pull from all other medical issues really being deemed non-essential. So with this plan, the cancer control plan with the Cancer Consortium members and stakeholders really determined that we really needed to hone in on a few issues, that being some of these cancers we've talked about today. But as that plan is kind of sunning down in 2022, we're thinking about the next year, probably a 5-year plan starting in 2023. How can we tie some of these recommendations in the development of the next plan, or thinking about how we're bringing stakeholders together to really discuss and plan the next plan, for lack of better words. So do you guys have any initial thoughts on that?
Well, I'll put a plug in for the Indiana Cancer Consortium, because the idea behind this is to bring together the partners who have the ability to do something on the ground. And so bringing together the partners and looking at what we could standardize in terms of approach, I think would be very important. However, getting everyone on the same page in terms of the screenings are things that have some controversy in the guidelines. And like Dr. Henry mentioned, educating providers about what can be done with screening. For instance, colorectal cancer screening is one of the big problems. I think lung cancer screening is too, because I'm sure not all providers understand what the evidence-based guidelines are and how they've just recently changed for lung cancer screening. So I think the Indiana Cancer Consortium is positioned to help bring together our partners, which we have to do.
And I think events like this help in that way, because certainly when the plan is being formulated for the upcoming years, after this control plan is completed, events like this bring these issues to the forefront, and I'm sure these documents will be used in the construction of the plan. So I think events like this help in a great way at planning for the future and enhancing the alignment between all the organizations.
So, I'll add, I think the Indiana Cancer Control Plan is such a really strong document. It's your cancer control plan for your state whenever it's kind of all put together. And what we found with kind of putting together these national recommendations, I think more than ever, maybe because of COVID-19, maybe just because there's kind of we really want to rally around cancer screening. We all see a part to play in this. More than ever, we're seeing compromise, people coming to the table, wanting to be at the table, wanting to be in cooperative conversation through the National Consortium, through our national roundtables of the American Cancer Society. People want to convene. People want to start thinking about solutions. It's not just the regular public health folks anymore, and some specialty groups. It's industry. It's the advocacy groups. It's so many more now, and I hope that trickles down to the state. I hope you're feeling that with the ICC as well. And what's also been really nice about this opportunity is, the folks on the President's Cancer Panel, some folks that were involved in kind of the recommendations, but not all of them. And it's been an educational process to be able to talk about the comprehensive cancer control programs across the state that we have, whatever it is, 67, 70 different states, tribes, and territories funded for technical assistance for the states to build cancer control plans, for them to have their comprehensive cancer coalitions, to really identify that we already have great infrastructure in place and great partnership in place and great conversation happening, like this conversation here. So it's been a great educational opportunity from kind of taking this grassroots stuff that's happening that you all are doing, or the state level of stuff happening, and making sure people at the national level know this is here. Like, we can tap into this. It's not only partnerships with national organizations and state partnerships, but can that information and best practices roll up as much as we're trying to trickle that evidence, that those items down, those recommendations down. And I always think the best case examples that we have really come from those exemplary health systems or community health centers or advocacy groups or whatever it might be. That's really where you say, well, they did it, we can do it, so that's what we want to kind of make sure we're finding.
Absolutely. And I think there's been, the cancer control plan allows for that chance for synergy, right? Around, again, how Dr. Champion said, bringing stakeholders together with a lot of these great recommendations. And with the ACS's recommendations, the President's Cancer Panel recommendations aligning so closely, I think it does really give us an opportunity to have that strong voice and implement it in the cancer plan going forward. So I appreciate your thoughts.
Mary, can I ask a question?
Yeah.
So this is not the way it's supposed to go, but Caleb, that was really interesting. Is there a mechanism that to disseminate these unique innovative processes that small grassroots organizations are doing? Is that stuff disseminated through the American Cancer Society? By what mechanism?
Partnership reports, Dr. Henry.
What's that?
I share those on partnership reports throughout the state for the COC cancer committees. When we report out, sometimes we don't get as much time. I'm sure you understand that at the table to report, but it's actually on the larger report or the additional slides.
Do we get national level feedback in that way, or just state level initiatives?
Well, so for example, some of the information Caleb shared, we share when we report out. It may be a national meeting, just like there's a meeting coming up. Caleb, keep me honest here, April 13th, but I could have the date wrong, with the National Lung Cancer Roundtable. That's the type of information we put in our partnership reports.
Yeah, so I think on the ACS level, so there's a couple of ways to look at this. So there's no perfect way that's being done right now of what that looks like. So the best thing that we can do is, for folks like you all, or for folks like Rochelle, it's like identifying those really great case examples that are happening in the states level. And then can we say, like, I've got a story that's ready for the national stage. Can we spotlight it? So that's one way to bring it up. And then that way, our national roundtables can package together kind of webcasts that kind of showcase these. So NCC, the National Colorectal Cancer Roundtable, Lung Cancer Roundtable, each can kind of take their particular area, talk about what those look like, what were the best practices. We also put together resources on our resource centers for the national roundtables that have just built out case studies. So we have like in 2018 released a hospital systems guide, has like 10 different hospitals across the nation that really focus in on colorectal cancer. I talk about colorectal cancer screening because that's what I know, that's where I came from. That's what I know the best. So this is not the lung cancer roundtable, the HPV vaccination roundtable is just as great resources. I just know the colorectal cancer resource is the best. So I'm upping my knowledge on there. So please don't say I'm a little biased, but just wanted to, that's why I keep going back to colorectal cancer. But anyway, so we kind of have those resources and those case examples within those. And then like I mentioned, the National Achievement Awards, where we try to find, we get 60 applicants a year for different National Achievement Awards. Now that's ACS's side of it. Mary has a really great mechanism through the Indiana Cancer Consortium through the Comprehensive Cancer Control program with CDC. So there's a couple of places. One, she can trickle up national information, and so comp cancer programs can share what's happening across the state through their listservs and that kind of thing. And they're, that's where she's kind of got that ear to the ground. So I think tapping into that is really, really great. There's also this thing called the Comprehensive Cancer Control National Partnership, or National Partners, who also provides technical assistance down to specifically to ICC, to the Kentucky Cancer Consortium, the Michigan Cancer Consortium, like specifically technical assistance and help. Like they have like really good tip sheets on what to do for your cancer control plan. So like there are these things that are happening now. The delivery of that information can always be improved. And that's where we need to kind of hear at the national level, like, we're not hearing about this, or like, or at the local level, or at the national level, we say, man, how can we better get those systems up? So I think that some places that's there, but it can definitely be, using my terminology, strengthened, I guess. There's some weaknesses.
That's great. Yeah, thank you guys.
Yeah, absolutely. I would agree. I think they're all happening. Again, it's just not in one avenue, which again makes it really easy to miss things. But putting a plug in for the ICC newsletter, if you sign up, we send it monthly and even more often, and a lot of that information is in there. And we try to pull those best case examples where we can too. So just a little plug for our newsletter if you're not already signed up. But we are wrapping up. I think I kind of posed all the questions I initially planned, but I definitely want to open it up to anyone that's on the line. Feel free to come off mute if there's anything in the chat. I see someone had asked a question that they weren't familiar with the national roundtables, and we can definitely get that website and information. Oh, thanks, Caleb, so much.
He's fast.
Yeah.
Gotta be. I gotta jump on those opportunities. It keeps me in a job, I think. So I make sure I get in the link.
Definitely. Any other questions? Anything from the group?
Well, I will just say, well, maybe people are thinking of any final questions. I want to thank you all for allowing me to come and kind of share about the recommendations. I know I threw a lot at you. There's a lot to kind of digest. Please do feel free to follow up with any questions. I love the work of the Indiana Cancer Consortium, and I'm happy to be getting back involved with it. So I hope that we can kind of continue this conversation. I know we have a really great web series planned out here, talking about some of their market research and some things coming forward. So I really appreciate y'all letting me come in and crash the party, and appreciate Dr. Henry and Dr. Champion's time too, because it's such a learning experience for me to hear from you all and your expertise, and see where our recommendations are resonating, and see where, we have some work to do. So.
Yes, thank you. Thank you so much, Caleb, Dr. Henry, Dr. Champion, for coming today. I think there's a lot to process and a lot of great information, and we clearly have some work to do. But again, I'm excited we're having these conversations and seeing how we can take our conversations to action. So with that, we do have 3 more sessions of this webinar series. Gage has thankfully added that information and registration to the chat. We'll also put that in the follow-up and get you guys some great recordings and resources. So thank you everyone for being on today, and greatly appreciate it.
Thank you for having us.
Yeah, thank you.